Well, good evening, everyone, and welcome to another edition of ASPC's CardioCore webinar. And we are really thrilled to host this discussion on a critically important topic, which is cardiovascular risk assessment. And it's entitled From Framingham to Prevent. I'm Michael Shapiro, President of the American Society for Preventive Cardiology, and I'll be your host for this evening. And very grateful to have so many of you joining us yet again for what promises to be a really fantastic discussion. As always, we would like this to be as interactive as possible, so please feel free to use the chat function, type in your questions at any time, and we'll be able to have 20 to 25 minutes after the discussion to answer as many of your questions as possible. So tonight, we're really going to be discussing one of the foundational principles of preventive cardiology, which is quantitative risk assessment. This really sits at the core of what we do. And we've come a long way since the foundational Framingham work. And today, of course, we have new and innovative models, specifically the Prevent Risk Score. And that is what we're going to highlight during tonight's discussion. And to guide us through this talk, I'm really pleased to welcome a true authority in the field, a longtime colleague and friend, Dr. Sadiya Khan, who is really widely recognized as a global leader in cardiovascular risk assessment. And of course, she is one of the chief architects of the Prevent model. So I really can't think of anyone better to lead us through this discussion than Dr. Khan. Sadi received her medical degree from the Feinberg School of Medicine at Northwestern University. And after getting her MD, she stayed on at Northwestern for all of her clinical training, including internal medicine and cardiovascular medicine. And then after that, she obtained her master's degree in clinical investigation and also did a postdoc in cardiovascular disease epidemiology before joining the Northwestern faculty. She is extremely prolific with hundreds of publications in her name. She's received multiple awards for excellence in research, teaching, and patient care. So without further ado, I would like to introduce Dr. Sadiya Khan. Dr. Khan, the floor is yours.
It's really a wonderful pleasure to join you all for this webinar series to talk about risk prediction, which arguably may be the most important aspect of cardiovascular disease prevention. I'm really excited to spend some time taking a bit of a historical perspective and journey from Framingham to Prevent and talk about some of the nuances in the risk models, how they were developed, and how we can use them today. I have no relevant relationships with industry and have funding from NHLBI and AHA. So today's outline, first we'll discuss the goals of predicting risk of cardiovascular disease. I think this premise is really important to how we think about these models and how we use them. Second, we'll define the evolution of models for predicting risk of cardiovascular disease. And third, and perhaps most importantly, discuss the path forward to optimize risk-based prevention of cardiovascular disease for all. So getting started, if we think about the goal, risk prediction in and of itself is ubiquitous to all aspects of our daily life. Whether or not it's going to rain and you need an umbrella today, but especially in clinical practice, we want to identify who is going to get a disease so that we can decide how and when to intervene. Specifically, there are two key goals to risk prediction. First, identify those at increased risk. And second, use this information to intervene on those at increased risk. Now, perhaps that's a very simplified way to think about it, but part of that comes from this really, wonderful overview that was first presented by Jeffrey Rose, an epidemiologist, many decades ago that talked about this high-risk strategy for prevention, and particularly thinking about the idea that if we have a population that has a distribution of risk, we could treat everybody, but then we would expose a lot of people to medication that they may not need and may not benefit them, or take this high-risk approach where we really focus on the tail end of those people at increased risk to limit exposure to those who would have the greatest benefit. So this is often considered the strategy that we think about in risk prediction. This concept was built upon next when we moved forward to the Bethesda conference in the 1990s, where the idea really developed into one about risk assessment itself. So not just how do we operationalize the idea of targeting those at increased risk, but how do we calculate that risk? And in this series of documents that were published in 1996, the idea was to really think about absolute risk assessment with the goal to match the type and intensity of interventions with predicted risk for primary prevention of coronary heart disease. So this concept has been around for a long time and has really emerged in cardiovascular disease practice guidelines to also now extend to the high blood pressure guidelines in 2017. Of course, in cholesterol, it was reaffirmed in 2018, in the primary prevention guidelines in 2019, and then most recently, even in the heart failure guidelines. So this concept of risk assessment and using risk to guide prevention is become really widespread in our practice. But if we want to think about how we use these models to prevent cardiovascular disease, it's helpful to think about where these models came from and how they've changed over time as well. So let's take a little bit of a journey back and think about the Framingham risk score first as really the first foundational model to predict risk for coronary heart disease. This model was published in the 1990s and took advantage of data from the Framingham heart study starting from the 1970s and looked at a risk score that could quantify risk for coronary heart disease based on sex, age, cholesterol levels, blood pressure, diabetes, and smoking status. These very traditional risk factors that we know and use every day. The outcome in this model was fatal or non-fatal coronary heart disease and included a variety of definitions such as angina, MI, coronary insufficiency, and death due to coronary heart disease. Well, fast forward about 10 years, and we of course know and love the pooled cohort equations that we're all very familiar with using that were published in the 2013 as part of the ACC AHA guideline on assessment of cardiovascular risk. And here there were several advances that were made. In the predictors, you'll notice that we include now hypertension treatment status. The populations included here incorporated white and black adults and included race and sex stratified equations. And for the outcomes, they expanded beyond coronary heart disease to incorporate stroke, understanding that that was an important outcome that we also wanted to prevent. Since then, there have been some changes that we know that really highlighted the need to evolve our risk assessment approach. And I'm highlighting 4 key things here that went into the thought process for what we needed to develop a new risk model. First was the development of estimates that are generalizable to a diverse and contemporary U.S. population. So as we think about how the pooled cohort equations built on the Framingham risk score, can we further expand and really include a more diverse sample? Second, to expand the utility and relevance to the full armamentarium of prevention therapies. Both Framingham and pooled cohorts really focus on initiation of statins as our primary approach to prevention, but we now have really a ever-growing list of therapies that may be relevant for risk assessment. Third, align our predictors, specifically kidney disease and kidney function measures, and outcomes incorporating heart failure that are relevant to the growing interest and awareness of cardiovascular kidney metabolic health. And fourth, extend the time horizon to include young adults and the full life course, understanding that risk for disease is emerging earlier and earlier in the life course. So what do we know about what's changed since the Framingham risk score and pooled cohort equations have been developed? Well, we know that there's been remarkable progress in coronary heart disease death rates. And so over the last really 30 to 50 years, we've seen a remarkable decline in coronary heart disease mortality. Now, this has unfortunately been countered by remarkable increases in death due to other cardiovascular diseases, which includes heart failure and other key causes such as valvular heart disease and arrhythmias. So this together suggests that we need to think more broadly than coronary heart disease for risk assessment. Together, this brings up a need for a new prevention paradigm, and this really highlights and amplifies the importance of bringing together metabolic disease, chronic kidney disease, and the broader subtypes of cardiovascular disease together in our prevention paradigms and in our risk assessment paradigms. We know there's a complex interplay and common co-occurrence of these conditions that often overlap, that there's a synergistic relationship with higher cardiovascular disease risk and earlier onset of adverse outcomes and death when these co-occur. But there's also hope. We have a better scientific understanding of the underlying clinical risk factors of disease, which is important for predicting disease. We have a growing awareness of social drivers of risk and disease that are important for predicting risk, assessing and modifying risk. And third, we have evidence for novel therapies that have multi-system impact that don't just prevent heart disease, but prevent kidney failure and improve metabolic health. And so all of these things can come together and really help form the generation or genesis of defining the cardiovascular kidney metabolic syndrome construct. And what is CKM syndrome? I think you're all very familiar with this now, but it's a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity that together lead to poor health outcomes. And this was released with a presidential advisory and scientific statement a few years ago that helped to build on the need for the prediction equations that we'll talk about shortly now, with the scientific statement that outlined the rationale for these new risk prediction equations and the methods paper for the development of it that we'll go through now. So during the development of the PREVENT equations, there were several key analytic questions, and I want to break it up into three key pieces. First, which and what type of data sources should we use in developing a risk model to ensure a large, inclusive, and contemporary sample? Second, what are the best routinely available predictors to accurately predict risk of cardiovascular disease that also account for the growing burden of cardiovascular kidney metabolic syndrome? And third, what are the relevant outcomes that should be included to predict risk and account for the growing burden of heart failure that we see occurring that allow us to more comprehensively assess risk? These framing questions really helped us guide the development and validation of the models. So first, the populations. The data sets available for PREVENT really built upon what was there for the pooled cohort equations in terms of research cohorts, allowed us to use more contemporary data, and was further supplemented by electronic medical record data from Geisinger and Optum, which are two large EMR data sets that allowed us to have a large sample. Now, if we look at the time frame as well for the Framingham heart model, which we looked at earlier, the pooled cohort equations and the PREVENT equations, these bars reflect the data time period from which these models are based on, and PREVENT was able to really span the more contemporary dates to allow for more accurate risk assessment for our current patients. Next was the sample size. Being able to utilize EMR data helped to really expand from the small sample size of a single cohort that Framingham had access to the multiple cohorts that pooled cohort equations had access to, and really leverage national EMR data to get to a sample size of over 3 million for PREVENT. Moreover, this allowed us to have a representative sample that really reflected the U.S. population. You can see here by race and ethnicity for non-Hispanic white, non-Hispanic Black, Hispanic, Asian, and other race and ethnicity proportions that make up the U.S. Census in the green bar around the time of the PREVENT development years, as well as more contemporary years. And then in the blue bars, you see the PREVENT samples. And while there was underrepresentation of Hispanic and Asian adults, you can see that these equations included people from other backgrounds for the first time. So what about the predictors? What goes into the model and how do we best assess risk? Well, one of the first questions we asked was, what data are available to clinicians on a routine basis? Because if we build a model that has variables that aren't routinely used, it's not going to be able to be implemented or usable. And so we focused on the traditional risk factors that are known to be associated with cardiovascular disease and included new predictors that were readily available and also associated with cardiovascular disease, such as body mass index, estimated glomerular filtration rate to really assess kidney health, and included a new predictor of statin use so that we can make the models more usable even beyond one question of whether or not someone should be on a statin, and include those people who are already on statins. The schematic shown here designs how we thought about the design of the equations, where we thought of the base model as really the core model that includes the baseline predictors, and then these add-on models that incorporate additional predictors when available or indicated. And one of the reasons we wanted to do this add-on or build models was really because we know that these aren't factors that are always available or indicated. For example, UACR is recommended for patients with diabetes, but not the general population. Hemoglobin A1C screening is recommended in a subset of the population. And for social deprivation index, we thought this was an important variable that would be readily accessible within most EMRs, but may not be readily accessible if you don't have an EMR, if you don't have the address or zip code. And so wanted to provide opportunities for clinicians to use this model, even when any of these predictors were not available. What about the outcomes? We saw this progression from the Framingham risk model using coronary heart disease to the pooled cohort equations incorporating stroke, and the prevent equations further built on that and added in heart failure based on the growing burden that we see for cardiovascular disease. And so there were three main outcome models. First, for total CVD as a composite of ASCVD and heart failure, and then for each individual outcome, ASCVD or heart failure. So how did the model do? Shown here are the model performance statistics, the C statistic, which is a rank ordering that tells you how well do you identify someone who's going to have an event compared to someone who doesn't, and the calibration slope, how well does it match the observed and the predicted risk in your sample, where a slope of 1 is perfect alignment, and you can see that we're pretty close to that here for total cardiovascular disease. The C statistic between 0.76 and 0.79 is also in the good to excellent range as well, and very similar to what was seen for prior models. Shown here are those same model performance statistics, now looking at ASCVD. We know this is the outcome that was the focus of the pooled cohort equations and what many of our recommendations for statin therapies are based on. And we see, again, very good C statistics or that rank ordering or discrimination and calibration slopes that are close to 1. For heart failure, this was a newer outcome. There have been other models that have looked at prediction of heart failure, but this really allows us to understand who is going to go on to get heart failure from a general population without baseline cardiovascular disease. You can see the C statistic here is in that excellent range, 0.81 to 0.83, and the calibration slope is close to 1. So now that we have a model that works well and we've demonstrated that it predicts accurately, it discriminates people who are going to have an event, it is well calibrated, let's talk about the path forward. How do we optimize risk-based prevention? Well, first, and I think foremost, one of the predictors that I didn't mention, because it wasn't included, is race and ethnicity. There's a growing awareness that race and ethnicity are social constructs and that clinical care algorithms should not differentiate care and management based on race. But we do know that racial differences exist in cardiovascular disease risk and significant and unacceptable disparities exist. So early on, one of our first questions was how well does the model do for predicting risk of CVD or ASCVD by race and ethnicity? And you can see here for Asian adults, Black adults, Hispanic adults, and white adults, our calibration slopes are very similar, very close to 1, although we see some variation with slight underestimation in Black adults and slight overestimation in Asian adults. Importantly, when it was compared to the pooled cohort equations, we saw systematic overestimation for all race and ethnic groups by the pooled cohort equations. One of the key factors that is really important to highlight is that even though race is not included in the model, the risk factors that go into the model themselves account for some of the racial disparities in cardiovascular disease. These are data from the CARDIA study or coronary artery risk development in young adults study that looked at racial disparities in women in the cohort as well as similarly for men, and showed that when you adjust for clinical, lifestyle, psychosocial, environmental, and neighborhood factors, you actually attenuate the racial differences largely by adjusting for clinical factors and those same clinical factors that were included in the PREVENT models, so that nearly twofold disparity in cardiovascular disease risk between Black women and white women that were observed in the CARDIA study are explained by differences in cardiovascular disease risk factors such as hypertension and diabetes that are included in the model. We also know that there is geographic patterning based on where someone lives. These are census tract maps from where I live in Chicago that show the distribution of coronary heart disease and the social vulnerability index. We can see that in the south and west parts of Chicago, there is concentration and overlap of both coronary heart disease and higher vulnerability. So the inclusion of the social vulnerability index or social deprivation index in the PREVENT models allows us to capture some of this place-based risk. The calculator is available online. I have a QR code here as well as the URL for anyone who wants to access it and take a look at it. And I wanted to spend a little bit of time just walking through a scenario. So if you have a 55-year-old patient, this is a patient that I saw, and I put in the numbers for the cholesterol, the blood pressure. She's a non-smoker. She's not on antihypertensive medication, not taking statin medication. And based on her current risk without diabetes, I get a predicted 10-year risk of 2.7%. One of the reasons I wanted to work through this scenario is because of the availability of having an assessment of kidney function. You can see how the risk changes for this hypothetical person if she also had stage 3 chronic kidney disease. Her risk would actually be about 5.3%. Now she had diabetes, but now no chronic kidney disease, similar risk about 6.2%. And then I think most impactfully, if she had both CKD and diabetes, that risk would be about 12%. So really important to think about the interaction of these risk factors and how they amplify risk. It's super important with any new model to think about external and ongoing validation efforts, and there have been several publications in the last several years that have looked at this. These are 2 studies coming out of California. That is perhaps one of the most diverse states in the United States and incorporates a higher proportion of Asian and Hispanic adults, which was a limitation in the PREVENT development. And in the first graph, you see that observed and predicted risk really lining up at about a slope of close to 1, and the C index in that analysis of 0.74. These are data from the KP Southern California system. On the second panel are data from the Sutter Health system that looked at a very diverse sample of adults as well from Northern California, and you can see the bars that show the observed to predicted risks for cardiovascular disease really match up overall, but importantly by race and ethnicity. And you can see those slope ranges are between 0.71 to 1.18, and the C index was good to excellent from 0.77 to 0.84. This paper also further showed some data on disaggregated Asian and Hispanic groups, which is really important and an area of growing interest in research. There have also been efforts within the VA system to take a look at the PREVENT equations, and this is a paper that was recently published in Nature Medicine that looked at over 2.5 million veterans and evaluated the PREVENT CVD, ASCVD, and compared it with the pooled cohort equations in the panels shown here. So you can see the predicted risk and observed risk in each of these panels, and different colors designate race and ethnic groups. You can see for both PREVENT models, you see good alignment across that slope or perfect line of 1, and for the pooled cohort equations, overestimation in this diverse sample. But current guidelines recommend risk thresholds based on the pooled cohort equations. So the 2018 cholesterol guidelines recommend the use of the pooled cohort equations with that 5 to 7.5% as borderline and greater than or equal to 7.5% to 20% as intermediate, and high risk is greater than or equal to 20%. And we're all very, very familiar with that pooled cohort equation threshold of 7.5% for statin treatment, but these are based on the pooled cohort equations. So what do we do right now? Well, I wanted to take a little step back and think about how different risk models have been implemented into guidelines to share a little bit, I think, of where we're going. So when the Framingham risk score was developed, we saw the ATP3 guidelines come out shortly after it. The pooled cohort equations were developed in parallel with the ACC-AHA guidelines, and we've seen several expert consensus pathways from the ACC in the interim as we're waiting for updated guidelines. And now with the development of the PREVENT guidelines, I think we're really waiting for this next set of prevention suite of guidelines that are due out on blood pressure, cholesterol, and CKM syndrome that will help us and inform us on how to use the risk model and what thresholds are needed. But how to use PREVENT today? Don Lloyd-Jones and I authored this viewpoint in JAMA to really try to address the question. We have a new model, but we don't yet have thresholds. And so the foundational principles that were discussed in the 2013 guidelines still remain relevant. And we know that we can now predict risk or estimate risk with greater precision. And we await the guidelines to really inform how to operationalize this new model. So I want to summarize with a few key takeaways of CVD risk prediction, a tale over 3+ decades. We talked about the evolution of risk prediction models from Framingham to the pooled cohort equations to the PREVENT equations that have each leveraged increasing availability of larger, more diverse, and more contemporary data sets. Second, modern approaches to risk prediction need to account for this growing burden of cardiovascular kidney metabolic syndrome in the population with relevant predictors and outcomes as PREVENT has done. We looked at data that show that PREVENT accurately and precisely predicts risk for total cardiovascular disease, as well as ASCVD and heart failure with broad generalizability in diverse US samples. And lastly, and most importantly, the risk model is just the first step to success in risk-based prevention. We don't have a crystal ball in who is going to have an event or not, but really trying to come up with accurate and precise probabilistic estimates are the first step, and future research is needed on risk thresholds and equitable implementation of these preventive therapies. Thank you so much for your time and attention. Looking forward to this discussion and questions as they come in.
Well, Dr. Khan, we're really honored that you're joining us tonight to talk about such a hot topic. And, we have a lot of listeners on the line tonight, so we're going to have plenty of time for questions and answers, and I can see plenty of questions coming in now. And I would encourage all of the viewers to use the chat function to put in whatever questions you have for Dr. Khan. So I can see right off the bat, Sadiya, there's a really excellent question, and you probably get this asked pretty frequently, which is that we're all used to the risk thresholds with the pooled cohort equations, right? Everybody's familiar with the 7.5% and 20% thresholds, have an idea of how to work with those. But it appears that PREVENT maybe doesn't have established cut points just yet. So should clinicians apply the same thresholds that they're used to, or does PREVENT require new thresholds? And if they do require new thresholds, is it ready for use in routine practice at this time?
Yeah, it's a great question. First of all, I want to thank you, ASPC, and all of the organizers for having me and really making this such a wonderful opportunity to share a little bit more about some of these back stories and kind of how these decisions were made and some of the discussions that are going for how we define these thresholds. I think the first thing to remember is probably in 2013, for some of us who may remember when pooled cohorts rolled out, 7.5 wasn't that familiar. And like with everything when it's new, there's a little bit of time that's needed to get used to this change and understand where it comes from. And I think that's where we want to probably try to spend some of the time, is thinking about, what does the threshold mean? How do we use it to identify the patients that are most likely to benefit from the therapy that we're thinking about? And for pooled cohort, it was just for statins. But one of the nice and exciting things, although maybe more complicated things, is we have a lot more than statins now to offer. And how do we interpret that? And a lot of that, I think, goes back to perhaps understanding where 7.5% even came from. And that really was based on the fact that statin trials showed benefit somewhere around the 5% range. And there was an appreciation even then when pooled cohorts was developed that we're probably overestimating risk a little bit. And so 7.5% was born. And it wasn't necessarily that 7.5% is this perfect number, or that risk prediction can be that precise, that we know that you're 7.4% versus 7.6%. And I think that gives us a really great starting point as we start thinking about, well, now that we have a more accurate model, now that we have more data on statin safety, and that statin risk for diabetes is probably at about 3%, somewhere in that 3 to 5% range is fair game for benefit for the ASCVD equation for prevent.
Mhm. Great. That makes a lot of sense. Um, one of our listeners has a first acknowledgement, thanking you for your work in this area and congratulating you on your work with Prevent and also being a co-author in the recent ACC/HA blood pressure guidelines. So congratulations on that. And the specific question is, what is your view of the use of longer-term risk measures beyond 10 years to trigger a recommendation for statins or even for coronary calcium testing?
Yeah, this is a great question. And I think one of the wonderful opportunities that we have in refining risk and starting to assess risk earlier. And you had a wonderful piece in the European Journal of Preventive Cardiology, really amplifying this point of we have to start earlier. And so one of the things that we wanted to accomplish with the prevent equations was 30-year risk estimation. So we can get a sense of what is the risk over the longer term. But with that comes some challenges in how can you best interpret what is a high 30-year risk. So I think that's another area where there's a lot of opportunity for ongoing work. In terms of coronary artery calcium, I think both that and the exact threshold, even though I gave a range earlier, I think we need to wait for the next set of guidelines to really be able to help us define that.
Right. That makes sense. Obviously, Prevent expands the scope of risk. So it incorporates heart failure and, of course, the CKM risk model in addition to ASCVD. And the question is, how do you see this influencing preventive strategies and routine practice?
So in terms of the prevent equations, if I'm understanding the question related to the specific outcomes.
Yeah. So in other words, I think we're all familiar with, we're comfortable with the idea that, statins can reduce risk of ASCVD. But, now, especially with the incorporation of, heart failure risk and a composite, cardiovascular disease risk, how might using those risk equations influence the types of preventive strategies that, clinicians might use when assessing risk with that prevent score?
Yeah, I think it's really exciting to have this opportunity to have multiple outputs, but your question's spot on. It's also really overwhelming. How many different risk equations and risk estimates can you give a patient? And I think it has to do with how do you start to streamline what you're going to do from it. So in the blood pressure guideline discussion, one of the things we focused on was exactly that. We know that treating blood pressure lowers risk for ASCVD and heart failure. So we wanted to be able to capture that risk holistically, to the point made earlier that in order to actually make sure that we're treating people who are going to get benefit, we want to capture the full risk of CVD. And so in that case, the outcome for total CVD with ASCVD and heart failure was considered. I think as we get more sophisticated about our therapies and think about, is this therapy preventing ASCVD like statins or PCSK9 inhibitors? Or is this therapy preventing heart failure more than ASCVD like SGLT2 inhibitors? We may start to nuance those discussions.
Yeah, along those lines, there was a question that one of our listeners asked, what implications does this model have for the allocation of, say, SGLT2 inhibitors or GLP-1 receptor agonists? I don't know if you have any thoughts on that, using some of the more advanced therapies.
It's a great question. I think we have great trial data that suggests that in patients with diabetes and CKD, the SGLT2 inhibitors are excellent at preventing heart failure, and those with heart failure and those without baseline heart failure. What we don't yet know is at what risk threshold do we also see benefit for preventing heart failure? And I think that's a really interesting question, even without diabetes or CKD, because we know these medicines are safe if you don't have those conditions. Could you use them to prevent CKD? Could you use them to prevent heart failure? All really important outcomes. I think right now, what we have evidence for and where I use in my practice is trying to prioritize SGLT2 inhibitors in patients with diabetes and CKD so that we can prevent the risk of heart failure.
Great, thank you. I've seen several listeners ask sort of a variation of the same question, which is, there are multiple other blood-based biomarkers and imaging biomarkers that have strong prognostic power. We're all familiar with them: LPLA, ApoB, CRP, coronary artery calcium. And the question is, should any of these tools be integrated formally into risk equations, or should they remain sort of adjunctive?
Yeah, it was a really interesting discussion when we were deciding what belongs in the risk equation itself. And we thought about kidney function and different measures of metabolic health. And these biomarkers came up, right? They're widespread. We have great data that supports their association and prognostic role for CVD, particularly high sensitivity troponin, which is rampant, maybe too rampant for those of us getting consults for chest pain, BNP, LP little a, and CAC really, right? Direct to consumer CAC has taken off. And so should we incorporate some of these things? One of the foundational principles we wanted to use was to make sure that whatever the base equation was that we created was able to be implemented at scale in every practice. So it didn't require something special. But I think as we think about refining risk, because risk is probabilistic and there's no perfect model, there's no crystal ball in anything that we're doing, there are going to be people where there's going to be benefit. I think especially for LP little a, we know that if you get one measure, you have a sense of whether or not that moves your risk up or down a little bit. So that's helpful. If you have any evidence of diabetes, that might be a group where BNP can be especially helpful. And there are recommendations from the ADA to measure BNP. And I think there's considerations like that, but we don't have formal guidelines for these things. And that's where we're also limited.
Yeah, I really like what you said about risk factors being probabilistic. I think that, well, that, people know this subconsciously. Sometimes we forget it. And it's something that I talk to, not in that language, but I talk to patients about this and to trainees, which is that, and coronary calcium has taught this very loud and clear that, risk factors are probabilistic. Just because you have three or more risk factors doesn't necessarily mean you'll develop ASCVD. Obviously, you're far more likely to than somebody who doesn't have those risk factors, but they're not deterministic. And that's, I think, really where athero imaging really helps, because it tells us whether individuals have the disease, based on these risk factors or not. It also takes into account all of the things that we're not able to sort of understand, which are, resilience factors or negative risk factors. So I think it's, obviously the role of imaging has continued to take on more prominence over time for that reason. This is a really interesting question. Should UACR be a standard part of risk assessment? As it stands, it's optional, and also recognizing that not all patients have this information. And if you also want to place this in the context of blood pressure guidelines, feel free to do that as well.
Yeah, thanks for the shout out for the blood pressure guidelines. So this was definitely one of the changes between 2017 and the latest blood pressure guideline was recommending UACR in all patients with hypertension. I think we're realizing more and more what a simple but useful tool it can be to identify people with chronic kidney disease, even with normal GFR. And I think that's a really important distinction about understanding that you don't have to have a low GFR to have elevated UACR, and that the information itself is both important for management in terms of what would be recommended for treatment, but also for risk. The reason we didn't make it required is actually the point right there is it's not required currently. And the yield actually, if you don't have hypertension or diabetes or a low GFR, is pretty low. And so I think it's reasonable to say that we want to target this additional test if we're going to change our workflow in patients who are most likely to have CKD.
Yeah, that makes sense. Sticking with the theme of the hypertension guidelines, one of the aspects that I really like, because I ask my patients to do this all the time, is home blood pressure monitoring, ambulatory blood pressure monitoring. And the question is, should future iterations of PREVENT incorporate dynamic measures of blood pressure as opposed to what we usually do, which is a one-time measurement in the office? And we all know how those blood pressures are typically measured. What are your thoughts on that?
Yeah, it's a great question. Actually, it's one that we talked about even in the development phase because we had longitudinal EMR data. We said, well, shouldn't we just take advantage of all the data we have? And it becomes a little bit challenging from a modeling perspective because some people have different amounts of input and some people have more visits and are able to come in more and less. But I think from a personalized standpoint, having that additional information or coming up with a way to integrate the home monitoring as an average, as a time and target. I think there are treatment targets that are going to be really useful. I'm not quite sure from a modeling perspective, but there have been some studies that have shown that longitudinal or cumulative blood pressure improves risk discrimination. So kind of like the pack years idea
Yeah.
with blood pressure years. So I think there's a lot of possibility. It's I think a great idea for future research.
Yeah. Of course, this question is going to be asked, which is about implementation. It's frequently the most challenging part of anything that we do. So what are your thoughts about what barriers exist for, the widespread adoption of Prevent, and, what ideas do you have for them being overcome by healthcare systems?
Yeah, I think one of the biggest challenges with any new model is change. So first, I think it's getting more familiar, and I think topics like this and webinars like this are so helpful, and really appreciate you thinking of this idea so that we're getting more people familiar with the idea and what it's based off of. I think the second is helping make things easier, not harder. In general, healthcare and primary care clinicians are so swamped, it's so busy. Adding one more thing is not going to make things better or easier to deliver care. So automating this within EMRs, making sure it's not adding nudge fatigue or additional work, but really helping to support clinicians who are out there really in the field seeing dozens of patients a day to make it easier to use this. And third, I think, is the support from the guidelines. So when do we act? Because if it's just a number, then it's great. It's helpful for conversation. There are patients that may want that number, but I'm guessing most of them, like mine, just say, well, what do you want me to do about it?
Mhm.
And then it's a discussion of whether or not they're interested in medicine, lifestyle changes, or other options for how to lower that risk.
Couple of questions about looking into the future and your thoughts on, risk prediction and how that's going to evolve. So do you think that the future of risk prediction lies more in refining these kinds of population-based models? Obviously, Prevent represents a huge refinement over PCE for all of the reasons that you've discussed. So do you think it's going to be further refinement of then, what now we're using in Prevent to another population-based model? We're really moving towards the precision medicine approaches that would leverage genomic and wearable and machine learning data?
I think it's probably not going to be an either or, actually. I'm going to throw a curveball on the answer. I will say the skeptical part of me suggests that we know the precursors of heart disease very, very well. The risk factors that are known for CVD and have been known for several decades are well established. But I think there's a growing movement to gaining additional information and data about our own genetic risk and information from wearables and imaging. And there's greater access to that information directly to patients. And so I think the clinician's going to be left more with how do we integrate this into your care and how do we interpret this rather than it's going to be one or the other.
Yeah, great. And I'm mindful of the time, so I have one last question for you. And sort of, again, take out your crystal ball. If you had to predict what will the next generation risk equation look like 10 years from now, and what will Prevent have taught us by then?
Yeah, that's a great question. What can you answer it first? And then I can tell
You're the expert here, Sadiya. So yeah, I mean, it's a tough question. I guess, it's very much linked to the last question, which is, do you think are we going to really just be refining kind of the population-based models that we've been looking at, or do you think there's eventually going to be an emergence of adding orthogonal, lines of biology into risk equations?
Yeah, I know. I think we both have some perspective on where this could be. I see the last 30 years, if we look at Framingham, pooled cohort, Prevent, there's been solid growth over that time, incremental progress and better understanding risk factors. So I think there's going to be ongoing evolution and progress, and there should be, in how we better assess risk. Some of that may even be because there's going to be changes in population health. Like, one optimistic hope I have is that novel therapies means that risk is going to go down further and risk estimates are going to get lower. And maybe that's true. I think that might be overly optimistic. So I think what we'll see is continued building on where we are now with understanding risk factors, but perhaps refining on a more personalized level for individual patients.
Yeah, thank you for indulging on that question. And I think it's a perfect way to end. And, perhaps in 10 years, we'll be able to have this conversation again and reflect back on all of this. So, Sadiya, thank you so much for spending the evening with us. I know that I and all of our listeners have learned so much. So thanks again. And we'll just let everybody who's tuning in know that we will have our next CardioCore lecture in about a month. Dr. Vijay Nambi from Baylor College of Medicine is going to be talking to us about residual risk of ASCVD. So again, thanks everybody, and we'll see you next month.
Thank you so much.